Welcome to Bedside Case Files, where we explore real patients, real findings, and the art of diagnostic reasoning right at the bedside. This is episode 4, The Man with Raccoon Eyes. This 70-year-old man presents with dyspnea. What do you notice about him? He has ecchymoses involving the eyelids of both eyes, giving him a raccoon-like appearance. Some of you may already be honing in on a specific diagnosis based entirely on these two pieces of data, raccoon eyes in a patient with dyspnea. Let's hold that thought for a moment. First, let's talk about dyspnea. The two main systems responsible for dyspnea are the heart and the lungs. The jugular venous pulse can serve as a pivot point. It can move you toward or away from the heart. With this in mind, let's evaluate the patient's neck. Here he's in the upright position, and we can see the pulse at least several centimeters above the clavicle, so it's elevated. By the way, this video serves as a good reminder that sometimes the internal jugular pulse is better seen on the left. Because the JVP is elevated, we know that we're dealing with something related to the heart. More history reveals the presence of orthopnea and paroxysmal nocturnal dyspnea. Our patient has the clinical syndrome of heart failure. A subsequent echocardiogram reveals normal left ventricular systolic function. Let's now return to our initial physical finding. Is there a cause of diastolic heart failure on that framework that's associated with easy bruising and raccoon eyes? Our hypothesis leads us to order an EKG, but before we even look at it, we should ask ourselves, based on our hypothesis, what are we specifically looking for on the EKG? The eyes can't see what the mind doesn't know. The EKG demonstrates reduced QRS voltage across all limb leads with preserved precordial voltage and P-wave prominence, an electrocardiographic pattern that's characteristic of a certain condition, one that should make you seek out other findings at the bedside. You might, for example, look at the patient's shoulders for the shoulder pad sign, as seen here in a different patient with the same underlying condition. There is prominent symmetric enlargement of the anterior deltoid muscles. You might also look at the patient's tongue, where you could see this finding, a scalloped tongue. The ridges along the edges form as a result of an enlarged tongue that constantly presses against the teeth. This example is from a different patient with the same underlying condition. With these findings in mind, we approach cardiac auscultation. But we just don't go in blindly. Based on our hypothesis, we anticipate what we might hear. The ears can't hear what the mind doesn't know. So we predict, and we anticipate, and we hear exactly what we expected. That's an S4 gallop, of course. Pay close attention. You will hear 3 sounds per heartbeat, one more than the usual. Where is that extra sound? Is it near S1 or is it near S2? The extra sound in this case is near S1, and it's heard over the apex of the heart with the bell of the stethoscope, indicating that it's an S4 gallop. So what condition underlies these bedside findings, and also presents with heart failure, an S4 gallop, and a low voltage EKG? That condition is, of course, cardiac amyloidosis. Endomyocardial biopsy confirms what we already know. Our patient's eyelid bruising, sometimes called raccoon eyes, is an important clinical clue. In systemic amyloidosis, fragile periorbital vessels can rupture even with minimal trauma due to amyloid infiltration of the vascular walls. This leads to characteristic ecchymoses around the eyes, often accentuated after rubbing the area or even from minor pressure. While raccoon eyes can appear in other contexts, like a basilar skull fracture, in a patient with unexplained heart failure and a low voltage EKG, this important finding points toward cardiac amyloidosis. The EKG offers another important clue. Here we see reduced limb lead QRS voltage, all under 0.5 millivolts, with relatively preserved precordial voltage. That pattern is characteristic of cardiac amyloidosis. The presence of low voltage, out of proportion to the apparent degree of ventricular thickening on imaging, is typical. The reason is that amyloid protein infiltrates the myocardium, increasing wall thickness not from muscle hypertrophy, but from extracellular deposition, producing a thick heart that generates less electrical signal. You can also appreciate P-wave prominence reflecting atrial enlargement, another common feature as the atria stiffen and struggle to fill a non-compliant ventricle. Systemic amyloidosis is a multi-organ infiltrative disease caused by extracellular deposition of misfolded protein fibrils. The clinical presentation depends on which organs are affected: the heart, kidneys, liver, nerves, or soft tissues. When the heart is involved, amyloid infiltration leads to a restrictive cardiomyopathy. The ventricles become thick and stiff, but the cavity size remains small. Patients often present with heart failure in the setting of preserved ejection fraction. On exam, look for physical clues, including periorbital bruising, macroglossia, or the shoulder pad sign. On EKG, low limb lead voltage with preserved precordial voltage can be a key finding. Diagnosis requires a high index of suspicion, followed by tissue biopsy with Congo red staining and confirmation of amyloid type. Recognizing these clinical patterns early is critical because while the disease remains challenging, targeted therapies for specific amyloid types are now improving outcomes. I hope you enjoyed today's case. I'm Andre Mansour, and this is Bedside Case Files.